So this becomes a vicious cycle where one culprit is promoting another culprit. Stress is a big contributor to obesity, which people seldom acknowledge. Leptin is a very novel discovery, discovered some around 20-25 years back. It actually tells you when to stop eating. It is a satiety hormone. It tells you that you are full.
Welcome to today's podcast on MedSynapse, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we are honored to have renowned medical expert Dr. Bharat Saboo with us. He will be shedding light on growing concerns that's often overlooked but has a profound impact on health, that is central obesity. Dr. Saboo is a leading diabetologist, Amazon bestseller author, and the managing director of Prayag Diabetic Center in Indore. With over 2 decades of expertise in diabetic care, obesity management, and metabolic disorder, he has received accolades such as the Distinguished Clinician of the Year by the American College of Physicians. Also, he has awarded RSSDI USP Innovation Award in Challenging Times. And last but not the least, the JPEF USP Diabetic Technology Innovation Award. Dr. Saboo is in the forefront of innovative healthcare solution. Dr. Saboo, welcome to the podcast.
Thank you, ma'am.
So let's start with the first question. From a clinical perspective, how does obesity contribute to inflammatory responses, and what role does chronic low-grade inflammation plays in comorbidities? Also, can inflammatory therapies plays a role alongside lifestyle changes?
Okay, so it's a really interesting question. First of all, thanks for this. We will take one by one. This is a 3-part question. So first, obesity, because we all know central obesity, it is a real culprit and it is associated with chronic low-grade inflammation, which is there. And adipose tissue is the tissue which contributes to this central obesity. So what adipose tissue does, it is actually visceral fat. The fat around the viscera, the visceral organs have a fat lining alongside them, and this fat is the actual culprit. What it does, it actually releases pro-inflammatory cytokines in medical terms, which are like TNF-alpha, interleukin B6 and CRP. All these things are released, which contribute to inflammation, which is systemic. The systemic inflammation is there. This actually disrupts the whole metabolic milieu of the body, the metabolic processes which are leading to insulin resistance, type 2 diabetes, even the cardiovascular disorders. So all these take place due to all these inflammatory disruptions. Now, your question was related to, if I remember clearly, does anti-inflammatory therapy play any role? Yes, because the progenitor is inflammation. So any anti-inflammatory therapy which is working against inflammation of body will definitely help. So when we see these sort of therapies into play, just like therapies which are directed towards interleukin 1 beta or omega-3 fatty acids, even the newer molecules of diabetes like SGLT2 inhibitors which have shown anti-inflammatory roles. So these actually can contribute in a better way to reduce the inflammation, and this inflammation, once it is reduced, it reduces the impact of obesity or the impact which obesity causes on body per se. So this is a cycle, and if we want to disrupt this cycle, we need to go away with the inflammatory effects of the adipose tissue, which is around our viscera. So either one way we need to reduce the visceral fat, or another way we need to reduce the inflammatory process, because they go like hand in glove sort of mechanism.
Dr. Bharat, does hormones have any part in this inflammation to the visceral part?
Yes, because hormones are the things which are interrupted by this visceral fat, because abdominal obesity, we all know, is linked with hormonal imbalance. The first and the commonest is insulin. Insulin resistance is very common when there is a high visceral fat. We all know this, and that is why we people who are working alongside the metabolic milieu domain, we always target on the visceral fat value. We are more interested in the visceral fat content than anything else. We are not bothered about the weight. We are not bothered about the abdominal obesity to an extent, but what we are looking at is the visceral fat, because insulin, we all know, is an anabolic hormone. It promotes growth. And it actually, what it does, it takes up the glucose and stores it as fat. So this is the basic mechanism how insulin works. Now, what happens is when there is visceral obesity, there occurs an insulin resistance. The insulin is not able to work. So the signaling mechanism becomes impaired. The pancreas secretes more of insulin. More of insulin leads to more accumulation of fat. More accumulation of fat leads to obesity. Again, more insulin resistance. So this becomes a vicious cycle where one culprit is promoting another culprit. Secondly, cortisol is the second hormone. We all call it as a stress hormone. This is commonly known as a stress hormone because it is released in stressful situations, let it be physical or emotional stress. Now, what this cortisol does, when cortisol levels are chronically elevated, this cortisol promotes lipogenesis. Lipogenesis is the process where fat production is there, and it inhibits the lipolysis, the process where the fat is broken down. So what cortisol is again doing, it is again promoting the fat deposition, especially around the viscera. So visceral fat cells are increased, and this actually is the reason why we always tell stress is a big contributor to obesity, which people seldom acknowledge. Lack of sleep is a big contributor to obesity because these two things, these two hormones mainly, insulin and cortisol, they are governed by the stress levels. Third, the new kid in the block is leptin. Leptin is a very novel discovery, discovered some around 20-25 years back. This is a really interesting hormone. So what it does, it actually tells you when to stop eating. It is a satiety hormone. It tells you that you are full. Now the contradiction is when there is increase in visceral fat, there occurs a blunting of leptin signaling to the brain. So brain cannot register the leptin signals. So brain becomes resistance. So just like insulin resistance, there is a resistance to leptin. The leptin resistance takes place, and this leptin resistance leads to overeating. We see people where they can't resist eating. We tell them that you are eating more, but they can't resist, and the problem lies in leptin levels. So this leptin, what it does, it increases the intake and it reduces the expenditure. So it again creates a vicious cycle of fat accumulation. So if we address these hormonal imbalance, which we are able to do by grace of God, now the science has progressed so much that we are able to address these hormonal imbalances along with physical activity and dietary modification, we can break this vicious cycle of fat deposition.
So you touched upon very important aspect of endocrine hormone, the release of cortisol, the stress hormone. So how does chronic stress and hypercortisolism play a big role in fat accumulation, and how does dysfunction in the hypothalamic-pituitary-adrenal, that is HPA axis, contribute to this?
Wonderful. So if we dig down further into this cortisol domain, now we see that chronic stress, as I told you, it leads to prolonged activation of hypothalamic-pituitary axis. There is an axis in body which is consisting of hypothalamus and pituitary. This HPA axis actually is activated. Activation causes persistent release of cortisol. The cortisol is released persistently. What cortisol does, I have already told you that it increases the fat. So fat is increased. It again reduces the fat oxidation. So fat oxidation is reduced. So these things actually promote fat deposition in the body. So stress due to any reason disrupt the HPA. HPA leads to fat accumulation, and that is why cortisol is a direct contributor to the visceral fat, which is again, visceral fat is again a culprit for many things. Now, identification of this HPA axis is very important. So we need to measure the cortisol values. We can do the serum or salivary test. Doctors are very well aware of this. We can do the dexamethasone suppression test, and we should look clinically, because these are the tests, but we should look clinically for signs of hypercortisolism, just like a abdominal stria or buffalo hump or a overweight obese type 2 diabetes patient, because it is very common to have a hypercortisolism along with diabetes in an obese patient. So you should always be suspicious. Again, the key lies in behavioral therapies, some sort of dietary interventions, and along with the correction of hypothalamo-pituitary axis by stress reduction, by maybe means of mindfulness or any other way it work around. But stress reduction is a key factor if we want to reduce the burden of this dysfunctional hypothalamo-pituitary axis.
So mindful exercise can actually reduce the visceral fat or the fat in general?
Although not directly, but yes, indirectly definitely it does, because mindfulness reduces the stress levels. Mindfulness reduces the cortisol levels. It has been proved by various studies. And once the cortisol levels are reduced, the sleep quality becomes better, And that is why we always say that if you sleep better, you are having a less chance to become obese. Those people who sleep less have a more chance to become obese. So this is indirect correlation, but yes, it is very well there.
Okay, on that note, there is a research that visceral fats are more common in men. So how does it impact metabolic syndrome risk compared to the women?
Look, it is really interesting. It is a fight between two hormones, testosterone and estrogen. So men definitely they have a higher level of testosterone, and testosterone is a property to influence the fat deposition around the viscera, that is visceral fat accumulation. And by virtue of that, men are cursed to have more of metabolic disorders, more of cardiovascular disorders, and they tend to store fat in the abdominal region. So the abdominal fat is metabolically active. It is to be noted that this fat which is around viscera, it in itself acts as an endocrine sort of organ, and it is metabolically active. So it increases the risk of metabolic syndrome. It is metabolically active to deactivate the metabolic axis. Now it again causes cardiovascular disorder, type 2 diabetes mellitus, MASLD, and all these things. Female have more of estrogen. Now estrogen has a typical property. It promotes subcutaneous fat deposition. It doesn't promote visceral fat deposition. It promotes subcutaneous fat deposition.
Okay.
And it is specifically in the region of hips and thighs. So if you observe, yes, so young females, they have a more fat deposition around hips and thighs. But the beauty is this fat which is around hips and thighs is not metabolically active. So they are not having those ill effects of visceral fat, which is there more in men. Now again, post menopause, there is a shift. The estrogen comes down, the testosterone level rises, and then female have more of visceral fat. So that is the point where female become more prone to cardiovascular disorder, metabolic syndrome, and metabolic disorder. So this is a very beautiful fight between these two hormones. Over and above that, there is a genetic predisposition, which is different between male and female. So there are certain genes which are linked to the fat deposition and distribution specifically of fat. They are expressed differently in men and women. So these are the two things which differentiate a male pattern of fat deposition from a female pattern of fat deposition.
So, as you have perfectly explained all the differentiation factors of men and women and the age group, how they affect it. So, we'll talk about the management of it, like therapies, GLP-1 receptor agonist, and endoscopic approaches. How does compare to bariatric surgery in managing chronic obesity around the trunk area?
Very, very good question, because the world is flooded with misconceptions about all these three therapies, first of all. So basically, we hear three types of therapies. One are medicinal therapies, which are GLP-1 based therapies mainly, which are usually medicines, and there is no intervention. Second is balloon sort of therapy, where endoscopically a balloon is inserted and inflated, and it is shown to reduce weight. Third is definitive therapy, which is a bariatric surgery, where we do a surgery and we reduce the size of intestine and duodenum, and this is how it works. So basically, if we contrast between all these three things, GLP-1, basically they reduce appetite because they correct the leptin imbalance. The leptin resistance is corrected, which I talked about. They result in a weight loss of, let's say, 10 to 15% with current ongoing therapy. Tirzepatide claims to around 20%, 25%. The trial data is really encouraging. So we can aim and achieve up to 30% of weight loss. 30% of existing weight can be lost with the help of these GLP-1 based therapies. But there is a caveat also, because these therapies, they suppress appetite. So nausea and all these gastrointestinal side effects are much common with these sort of therapies. Now, coming to the sustainability part, because these therapies are non-surgical and they are to be taken on a day-to-day basis. So in my clinical practice, I have found it is very difficult to have a patient compliant on all these therapies, because they need to take it on their own and they sometimes miss the dose. And actually, these therapies have an advantage also because they are non-invasive, so risk is very less. They are suitable for those patients, specifically in my domain, where the surgery is not possible. If the patient is not surgical candidate, so we can go for that. We can go for these sort of therapies. We can very well go ahead with these sort of therapies. Now, when we talk about bariatric surgery remains gold standard for weight loss till date. a fight will occur soon between newer anti-obesity molecule and bariatric surgery, because newer molecule also claim the same amount of weight loss just as bariatric surgery, which is 20 to 30%. So bariatric surgery is a definitive procedure. It is more durable because once it is done, patient cannot do anything. So it is not having any caveat regarding compliances or on a day-to-day basis. But yes, it carries risk because there are risk of infection, specifically in diabetic patients who are usually obese. It carries a risk of infection. Then nutritional deficiencies occur because there is a lack of eating after this, and then post-surgical complication like leaks and all those things can occur. So these are different contrasting features between all these three type of therapies. And actually, to be very precise, it should be up to the patient to decide on which therapy he wants to go. If he is comfortable with a bariatric surgery and he is not willing to do a day-to-day injection of GLP-1 or a tablet of GLP-1, he should go ahead with that. And if he is really fearful of surgery or is unfit for surgery, we should not delay, but we should begin with the GLP-1 based therapies, because ultimately we need to cut down on obesity as soon as possible till it becomes a bigger problem.
Thank you, Dr. Saboo. It was an enlightening discussion with you. You shared your expertise. I'm sure the future healthcare professionals will really love the information you have shared.
Thank you. Thank you.
And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, or contribute to the ongoing evolution of healthcare. So until next time, stay healthy.